Hi. So here's part two of the substance abuse lecture. So I'm looking at slide number 9 now, and I put a read-only article on there. It's called Faces of Persons with Addiction. So it's a read, it's a Word document, but it'll show you pictures of people before they started using and were addicted to substance, and then how they look today. You can really see the toll that using substance takes on someone. So then in slide 10, these are some meanings that you should know. Dependency, addiction, um, substance becomes a priority in life, the BAL, blood alcohol level of alcohol, that we hear so often in terms of driving. So dependency is physiological dependence on a substance. It's associated with tolerance and withdrawal. So again, the more you would need to drink to get the same kind of effect from using alcohol. And if you stop abruptly using alcohol or some of the other substances, you can go into withdrawal, which can be painful and physiologically unsafe to be in withdrawal without some support from healthcare givers. So addiction, it's again continued use of that substance in spite of all the consequences that come with it. And that person is denying that there's any problem and has a lot of consequences. It's sort of like, well, how's that working for you? You drink every weekend, then you go to work and you're irritable and tired. And how's that working for you? Substance use is their main goal in life. That's everything that they think about. Will get anxious in terms of having the next drink or being able to drink and or use. So that becomes a very big motivating factor. Blood alcohol level, we know that that's used in terms of legal amounts of being intoxicated. So the amount that one can metabolize per hour without becoming intoxicated, it's 1 ounce of liquor, 5-ounce glass of wine, and a 12-ounce can of beer. Now, you and I know from going to all the different eating places around that, they'll ask you, do you want a 12-ounce or a 16-ounce? So already you're in trouble if you get up and leave and not eat and not spend enough time to metabolize the alcohol. On the next slide, you can see the different levels, BAL levels, and what happens with those. Impaired judgment is 0.05, difficulty driving 0.1, and then all the way up to 0.5 where there can be respiratory failure and death. Again, I think about particularly young college students who just begin drinking, and they'll drink enormous amounts at a party. It's a drinking game, or they just keep chugging it and can go into respiratory failure and or a coma, and can die without anyone really noticing that they're not breathing. And then we're very aware of people brought into the emergency department who have alcohol poisoning. They've drank a huge amount of alcohol in a short period of time, and their blood alcohol level is high. Withdrawal begins when ingestion stops and detoxification begins. It's a physiological withdrawal, and it ranges from mild to severe, depending on the length and the amount of alcohol used. So someone who's been drinking for years and drinking a large amount, their withdrawal is going to be quite remarkable and dramatic. And people in withdrawal can absolutely have seizures and die. So it's a serious serious occurrence. We can see it beginning within 12 hours of that person's last use. So somebody comes into the hospital, they're having elective surgery, they drink, they drink before they came in, you know, within the time that you're getting ready for surgery, or, you know, starting them on some kind of treatment, they can begin to withdraw, and you can see some of the withdrawal symptoms. Seizures can begin within the first 48 hours as well, of the person being in withdrawal. We call it detoxification, is the care of that person with addiction to substance. And again, it can be very life-threatening. Slide 13 is a KJ assessment. It's a really nice, quick way to do an assessment for someone who is abusing or is addicted to some kind of substance. It's 4 pretty simple questions. And again, you got to remember that person might deny any one of these. For example, have you ever felt you ought to cut down or on drinking or using drugs? Oh, no, not really. I never really. And next one, have people annoyed you because they say, you know, boy, you're drinking a lot lately. Ever felt guilty about using alcohol or drugs? Or ever had a drink or used drugs first thing in the morning? You know, talk about it as an eye opener to steady your nerves. So 2 of those positive answers is a normal cutoff, although one positive answer might be telling you that they abuse alcohol or drugs. Any one of those, there's probably some abuse going on. Self-assessment, you really need to think about your own use of alcohol, substance, drugs. Also look at how you feel about people that we call alcoholics, or people with an alcohol addiction, people who have a drug addiction or using drugs. You really need to think about that and go back to, yeah, they shouldn't be eating it or drinking it or taking it. However, they have an addiction. You or I might have to have a few beers here and there. We never get to where we're addicted to the substance, and we're fortunate because we know there's a strong genetic component to this. To me, I might have said this in part 1, but it is almost like poison for people who have that predisposition to addiction. 10% of nurses are estimated to be suffering from alcohol or drug addiction, and that's just you know, what we know. You know, people don't go around admitting to things like that, so there might be even a higher incidence of nurses being addicted to alcohol or drugs. 1 in every 10 nurses then, nurses you may be working with may be in recovery. You just don't know. They might avoid social gatherings, or, hey, let's go out and have a glass of wine after shift and have some dinner, and, oh, no, I really can't. And, you know, they may be hesitant to tell you that they're in recovery. It's great when people are honest about that, because I think it gives all of us permission to say how things are going for ourselves. Or they might be using. You know, we're in a great spot to have access to the medications that are can cause addiction. The benzodiazepines, the pain relievers, morphine, oxycodone, hydrocodone. When they've looked at all that, they've realized that that we, the healthcare providers, have been giving these opiates for years. You know, dentists might give months worth of hydrocodone to someone who's just had their tooth out. Now, I know all this has changed now, and it's had to change because of the way we were prescribing all these opiates. Assessment in a nursing process, willingness to change is crucial, critical. We use motivational interviewing now. It's non-threatening. It's a gentle way of moving someone through the process of change. For example, pre-contemplation stage in motivational interviewing, that person hasn't even admitted having a problem. They're not considering going for treatment. And a lot of people that you work with, you might be meeting them right at that place, and gently you'll begin working with them, hopefully, around recognizing what's happening for them, and not being judging, giving them a lot of support, and that, there are ways to treat this. Assessment includes clinical exam, pattern of substance use. Sometimes it's picking up on, how many drinks do you usually have in a day? Oh, I don't drink every day. I just drink once a week, maybe a glass of wine with Sunday dinner. As contrasted with someone like, oh, I don't drink that much every day, maybe 3 or 4 beers. If it's hot, maybe 5. And so they're minimizing their alcohol or drug use. People we suspect of having a problem with abuse or addiction will most always minimize the amount that they use. Oh, I only have one glass of beer, and the glass might be this high. I mean, we forget to ask, well, how tall is the glass? Mental health problems, history of trauma, abuse. A lot of people have been traumatized, do use and can get in trouble with addiction. Family history of substance use, abuse, definitely a genetic component to this. So it's like anyone in your family been addicted to drugs or alcohol, or family you've seen as a problem drinker. Sometimes people will refer to that. Disabilities, and then of course individual strengths. We need to always consider that person and their strengths. It's a family disease, so the assessment includes the family. Families burn out, they give up hope. It's what we call tough love, when a family realizes that they've really created and enabled that person to use or to continue drinking. There's this term called codependence. A lot of times it's the spouse who will just try to get that person to stop. And so they'll, pour out all their booze. They'll call their employer when they're sick and they can't go in. They keep making accommodations for that person, when in fact, what's happening is they're enabling that person to stay in that pattern of drinking and using. The person themselves is the one who has to change and not drink, not use, and be in a lifelong recovery program, because there's no cure for this. Ask if family members are getting support. There's adult children of alcoholics, adult grandchildren of alcoholics, Al-Anon. They're all self-help groups. There's Alateen for kids that are living with parents who are abusing or addicted to alcohol. These are non-clinician led, so it's lay people who run these groups, and who knows better than persons who have been involved in being a family member or an active drinker or a user. So they really depend on each other and support each other. The planning for this: identify the problem, set goals, which is not to use or abuse substance. There's no cure. We talk about recovery. Continuum of care is involved in recovery. Lifelong goal is abstinence. There are medical treatments involved, different levels of care. Detox oftentimes is done on a medical unit. Actually, it is done on a medical unit. Partial hospitalization for persons who are abusing or using. Intensive outpatient treatment. This is where people might go 2-3 times a week and be in an AA group while they're there, led by a layperson. Might also get education from the staff there. People may be looking at their meds while they're there. Outpatient treatment, I would see some people who were actively using or in some kind of recovery, and I always saw my role as trying to clarify with them and trying to help them get through that thick denial piece, defense mechanism of denial in a gentle way, and also supporting them in recovery, you know, and doing one-to-one therapy with them. Rehabilitation, there are rehab programs, you know, you're probably aware of some of them. Some are very costly. Some might be within a medical community. Halfway houses for people who are trying to stop using and drinking. Sober houses where people live and don't drink or use at all, and if they do, they're not able to stay there because one of the rules is you won't use or abuse. We see a lot of sober dorms now as part of college campuses for students who are in recovery or who are very aware that they're abusing substance or alcohol. Self-help, community-based groups, again, Alateen, Al-Anon are the big ones. Brief interventions, detox, counseling, relapse prevention, psychobiological, pharmacological, health teaching, health promotion, advocates, self-help groups. Those are all interventions that we use as nurses and other clinicians do as well. That's slide 21, just so you know where I am. Self-help groups, AA, Alcoholics Anonymous, NA, Narcotic Anonymous, OA, Overeaters Anonymous, GA, Gamblers Anonymous. And there are many other groups that are self-help, and they're always evolving depending on what's going on in our culture. So evaluation, that person is not using, they remain clean and sober, they continue with support programs. Sometimes people say, well, I'm all right now, I don't need to go to my AA meetings. And quite honestly, AA is such an important treatment. Now, some people will refuse to go. They don't like the whole premise of, I think that the word God is in there, and some people say they go and all they think about is going out and getting a drink after. So some people will tell you it doesn't work for them. But for many, many people, it does. The other piece is it's not uncommon for a person to have a slip. And I think I talked about that in part 1, that it's not a failure. Get sober. Stop using right now. Don't use again. Take it from here. You know, it's just like dieting. You eat a hot fudge sundae, it's okay, go back to your diet. Doesn't mean you're a failure or a bad person or whatever. Just start again. You know, we know people will have shame and guilt and remorse. And sometimes that gets in the way. They think, oh, that's it. I'm no good. I'm never going to be any good. So symptoms of the abuse, addiction to alcohol, symptoms of withdrawal, and nursing considerations and care of the person in the detox unit are all things that you should be aware of. This next section on opioid epidemic, these are a couple of quick TED Talks in slide 25 that you should look at. They're pretty brief. And then to be aware that opiate addiction is one of the big scourges today in our culture. In Maine, it's horrendous. People are there's so many deaths from opiate overdose. So we include narcotics, morphine, heroin, codeine, fentanyl, hydromorphone, meperidine, methadone, buprenorphine, oxycodone, hydrocodone. And there's assessment symptoms of abuse that follow: hyperpyrexia, seizures, cardiac dysrhythmias, different kinds of mood states, anxiety, euphoria, sadness, depression, insomnia, no interest in sex. I mean, that can be one of them too. And then, let's see, I think, oh, I know. And then in terms of withdrawal, and you may see this in people that come in through the medical system: watery eyes, runny nose, loss of appetite, irritability, tremors, panic, cramps, nausea. And then overdose certainly is severe respiratory depression, pinpoint pupils, coma. And if you see that, then you know that person most likely has had an overdose. And then in slide 28, our nursing interventions. Narcan has been a blessing when people are absolutely about to die and receive Narcan, then we can reverse that respiratory depression. Check levels of consciousness, vital signs, have lidocaine defibrillator available, case of cardiac arrest, treat for hyperthermia, and comfort measures. And you know, in there too, I said start IV. I mean, that's always a big piece when dealing with anyone in the ED who's in pretty tough shape. Chills and sweating are also symptoms of withdrawal, elevated blood pressure, hallucinations, and delusions. That should have gone, excuse me, that slide should have gone up with other symptoms of withdrawal. Sorry. All right, so then the next slide goes into barbiturates. And so I'm going to have you finish the slides. I've talked enough to you today. I don't mean to over talk, but I do. So there's barbiturates, hallucinogens, stimulants, cannabis, nicotine. All those certainly are substances that can be abused and can cause addiction. So we need to be mindful. So just to kind of follow up, Wednesday I'm going to go live on Zoom, and I hope you'll come and visit and stop in or stay on, and maybe we can chat a little and give each other some support. So I figure like 1:30 to 3-ish, kind of in that time frame, and for how long everyone wants to talk. I am going to get out the first case study to you Friday. It'll be on anger, hostility, and schizophrenia. It'll be case studies, maybe 1, 2, or 3, and 30 questions. There'll be multiple choice. I'm going to design an answer sheet, so all you'll have to do is tack that answer sheet on to an email to me so I can correct them. And then you'll have until Sunday night at 11:30 to do the case studies. Open book, absolutely. Use your text, use my talks, use your notes, the slides. Yeah, and let's see what else. Oh, as part of this module, there's 5 different pieces following the slides. Some of them are videos I really want you to watch. Brene Brown and Dr. Kevin McCauley does several little videos. They're very brief on dopamine in the brain and the physiologic process of addiction. And he's in recovery himself, so it's pretty amazing. Brene Brown is fabulous. She talks about shame, guilt, vulnerability. She was just on 60 Minutes last night, and she just did a podcast on vulnerability that you can look up and listen to. But she is pretty remarkable. She's in recovery herself. So she comes from that place of compassion and being honest, being vulnerable. I think we all feel that now, how vulnerable we all can be right now, and our friends and family. So, all right, take care. I'm going to certainly get announcements out to you, and I'll hopefully see you Wednesday. Okay, bye-bye.